It's the biggest killer of women worldwide. It's that old adage that we were taught that heart disease is a man's disease. It's just not true. The same disease can present quite differently in men and women. The diagnosis is often slower, it's often missed, they don't get the same management and the same care. And we're working to close that gap.
Hi, it's Jonathan.
Hi, it's Emma.
Crazy what I'm
Cut to the case.
Emma, how have you been?
Great, thanks, Jonathan. Any interesting cases of late?
Oh yeah, something came to mind. And it's International Women's Day coming up.
Oh, I'm so glad.
So I saw a lady just last night, 47-year-old lady, atypical chest pain.
Jonathan, atypical?
Atypical
What
chest
makes
pain.
it atypical?
Well, it wasn't really cardiac pain, but it could have been cardiac pain.
Okay, let's unpack atypical chest pain.
And to unpack that, we're very lucky to have...
Associate Professor Monique Watts. Welcome to Cut to the Case, Monique.
Thank you for having
Welcome,
me.
Monique.
We know you're an expert when it comes to the issue of atypical chest pain in women. We wanted to unpack that. What do you think of that word, atypical?
I think it can be a bit misleading, to be honest. I think the moment we hear, as clinicians, the moment we hear atypical, we think non-cardiac. And therefore our antenna goes down, we become less concerned and we do everything a lot more slowly. And we know this is problematic because we've seen that in women who tend to present with slightly different symptoms to men when they have cardiac pain, often are labelled as atypical, and then their diagnosis is often slower, it's often missed, they don't get the same management and the same care that they would otherwise get. So winding it right back to the beginning, labelling it as atypical really puts that patient at a
so
disadvantage.
that's what had me from the start. So I've said atypical chest pain, but that's what she's been in before with the same thing. So I went through the history, and the nature of the pain was actually central, but she had sort of neck pain and shortness of breath, and there were aches in other places and a lot of lethargy. And I think that threw me off a bit from, I don't know, what textbook angina or ischemic heart disease sounds like. What do you think, Emma?
Well, I think through having seen you speak a number of times, Monique, that I'm aware now that typical chest pain is pain for men, and for women often symptoms are quite different. Is that how you see it, Monique?
Absolutely. So the same disease, a myocardial infarct, can present quite differently in men and women. So men classically get that central retrosternal chest pain radiating down the left arm, and we all know what that is.
Yeah.
Women might get that pain, but it might not be so severe, and there might be other distracting or associated symptoms, dizziness or fatigue or nausea and vomiting or back pain, or sometimes women just get arm pain.
Yeah.
So I think that you mentioned possibly cardiac. I think that's a much better way to look at it. Is it cardiac pain, possibly cardiac pain, or not cardiac pain?
Okay, so we'll remove typical and atypical, and we'll start talking about cardiac pain, but also knowing that cardiac pain, the spectrum is really wider for women.
Absolutely.
Great.
I like that classification. That's much better.
Yeah.
My patient, she has an ECG. It's normal. Examination unremarkable. Pain is already better. All right. So what do I do? What would you do, Emma?
Well, she's having some blood tests to look for a raised troponin, and we need to interrogate her risk factors, Jonathan.
Okay, so she tells me hypertension. During one of her pregnancies, she had diabetes, and she's had this before. She actually tells me she's had atypical chest pain, but that's as far as I know.
So pregnancy history, Jonathan. Let's ask Monique.
Well, I asked her about diabetes.
Oh, diabetes. I see. Right, gotcha.
So
you stumbled across the pregnancy history.
And you know what? I reckon that's a risk factor.
Let's ask Monique.
Are there other unique risk factors or other female risk factors versus male risk factors? Is there a difference?
Yeah. So firstly, typical risk factors that we all know about that affect men and women still apply for women. So smoking, diabetes, cholesterol, family history. Interestingly though, some of these risk factors such as diabetes and smoking, perhaps a little bit more potent in women than men.
Okay.
But then separate to that, there are a whole lot of risk enhancers or other risk factors that are female specific, such as early menopause. So estrogen's really protective. The moment that natural estrogen falls away, the woman's risk really goes up through multiple mechanisms. So early menopause, and the earlier the menopause, the higher the risk. Pregnancy complications. So pregnancy is really like a stress test for the heart. So all of the changes that occur during pregnancy to the heart and the vasculature, if a woman doesn't cope with that or the placenta doesn't cope with that as well, manifesting in premature delivery, preeclampsia, gestational hypertension or gestational diabetes, shows that a woman is much more likely to develop heart disease, and at a younger age, not when she's 80 or 90, but within 10 to 15 years post-delivery. So just taking those very quick questions about menopause and obstetric history can give you a really big insight into a woman's vascular health.
That's such a big learning point. So we've got our traditional risk factors: hypertension, smoking, diabetes, cholesterol, but to add in an obstetric history.
It's a stress test.
And
I like it. You know,
absolutely.
it's a stress test.
And inquiring about menopause. That's great. I think we can all change that. That's fantastic.
So she's 47, so she's perimenopausal. I didn't take the full history, but so maybe that's part of it. But she's had the diabetes. So 2 troponins. The second one comes back normal. We do like a low risk pathway. Maybe that was wrong, but that's what I did. And second troponin normal after 2 hours. What do you do, Emma?
Well, she's got some risk factors, as I understand it. Well, I think she's probably at the moment safe to go home, but she'll need some follow-up.
Yeah,
what should she have?
No, early follow-up is a good point.
Yeah.
And then I think a discussion needs to be had about the best type of investigation. This is a woman who's got multiple risk factors, has presented twice with chest pain, for which we don't have an explanation. So we need to assess her coronaries, whether it's through a stress test or a CT coronary angiogram. That's sort of up to the clinician and the patient at the time, but definitely needs to, I would say, not be falsely reassured that it's not your heart, you're okay, because your troponins are normal. So that's one thing that definitely can happen. And 2, follow-up needs to be arranged. This is important.
Yeah. If she had a raised troponin, but then a normal angiogram, I'm sort of learning that there's other pathophysiology that we don't traditionally learn about in medical school or even in our specialist exams. Can you tell me about that?
Yeah, absolutely. So MNOCA, or myocardial infarction with non-obstructive coronaries, means that the patient presents with a syndrome like you've described. They've got features that would make you think this is truly a heart attack. But when we go looking for the blocked artery, which is what heart attacks are from in men, we find that the arteries are open.
Okay.
Which can create some confusion.
So you're saying in women it's different pathophysiology?
Absolutely.
Yeah,
absolutely.
Right.
Women are much more likely to suffer from MNOCA, so myocardial infarction without obstructive coronary arteries.
Can I ask, Monique, does MNOCA have any similarities in terms of morbidity to men, or is it a more benign condition?
No, definitely not a benign condition.
Okay.
And that's a really important point to get across. Again, and the normal angiogram doesn't mean your heart's okay, and it doesn't mean the pain wasn't coming from your heart. It means that we need to do further investigation. So patients with MNOCA have got similar morbidity to patients who've got single vessel coronary artery disease. So they're more likely to be back within 12 months with more chest pain in the emergency department. They're more likely to have worse outcomes.
So we need to chase them down in terms of investigations and treat them.
Yes.
Are women getting equitable treatment to men? Is it being recognised as much as it should be?
I think we're slowly getting there. It's well documented worldwide, in Australia and internationally, that women don't get the same diagnosis and management, and we're working to close that gap. But as you said, it's all about education and understanding that old adage that we were taught that heart disease is a man's disease. It's just not true, and it's not safe to think that way.
It's amazing. This information, this data, it's been around for ages. Yeah, it's just not quite getting through.
Yeah.
Like this is like 10 years old, 15 years old sort of information, and yet still we're kind of biased, and we're treating it, as a man diagnosis. And if you don't fit that classic thing, you're going a different way. So it's amazing.
Do you know, Jonathan, I feel a little bit embarrassed. I feel like I don't have a good grasp on this knowledge, and even these short learning points are so transformative for me as a clinician. I'm going to take a different risk factor history, including menopause and obstetric history, and I'm going to understand that conditions like MNOCA have a similar outcome to single vessel obstructive coronary disease in men. And that follow-up is so important, is that right?
So I'm not going to just say it's not your heart until we sort of drill down and get further. I think that's the thing. Before I send her home, say it was the first situation where a troponin's okay, would you start her on anything? Or if she came back again with angina or the same symptoms, would you start her on anti-anginal? Is that useful?
I think you want to know what you're treating.
Yeah.
It's not unreasonable to try some nitrates in the emergency department, because I tell you what, if the nitrates make the pain go away, that makes you maybe more likely. It is more likely cardiac pain.
So aspirin? Put her on some aspirin?
I think we don't know yet, because the mechanisms are so different. Aspirin's great if it's atherosclerotic disease, but if it's just possible angina and we don't know what's going on, then I think early follow-up is what's needed.
And so I think the decision point is, rather than just reassurance and everything's okay, it's really interrogate the information further and arrange early follow-up.
Absolutely.
And MNOCA is just a drop in the ocean as far as I'm aware. There's other conditions that women that manifest cardiac disease that are different in women. Is that right?
Yeah, so in your particular case, the 47-year-old woman, the most likely, if she was to have an infarct, SCAD would be a very big possibility, so spontaneous coronary artery dissection.
Which is more common in women, right?
90% of the time happens in women.
Yeah, wow.
90% of the time.
90%
Can we go, wow, because I knew it was more common, but
wow.
Really?
Okay. And
Wow.
so for those patients, if we're not doing ECGs early, if we're not listening to their symptoms, we're really doing them a disservice. So we just need to reframe. It's not atypical and typical. It's just cardiac pain and really opening our minds to what that might be.
Absolutely.
That's fantastic.
So in summary,
Go ahead.
Monique, what do you reckon? What are the top issues in women's chest pain?
Okay, so I think number one.
Top take-homes.
Top take-homes. Number one is that heart disease affects women as well as men. It's not just a man's disease affecting a woman. It affects, it's the biggest killer of women worldwide is coronary artery disease. Okay, so it's a woman's disease as well. Number two is that the pathophysiology and presentation can be very different in women. It's still heart disease, but it might be a slightly different pathophysiology. It might be SCAD, or it might be vasospasm, or it might be something different. But it can also present differently. So it may not have that classical central chest pain. It might be jaw pain, it might be arm pain, it might be a heaviness, feels like the bra's too tight, might be associated with a whole bunch of distracting symptoms, but it could still be cardiac pain. That's number two.
Number three, risk factors are different?
Absolutely. So women have the same traditional risk factors that men have, but there's a whole bunch of female-specific risk factors that include pregnancy complications, premature menopause. Really important to think about.
I'm going to add
those
that to my history taking.
Yeah, you could take a history the way I do.
Yeah.
I think they're probably the three main take-home
Yeah,
points.
great.
Absolutely.
And early follow-up is what I'm hearing, and don't dismiss that pain. So I'm really going to change my practice. And thank you so much for all your work that you do in this space. It's just incredibly important, and I'm sure it's transforming the lives of the women that you see.
Thank you. Well, thank you very much for having me.
Thanks for all your work.
Thanks, everyone.
All right. See you next time.